Good afternoon, everyone. My name is Rebecca Saltzbaugh, and I'm with the Christopher and Dana Reeve Foundation's Peer and Family Support Program. I'd like to welcome everyone to today's webinar on helping peers who are experiencing depression. Thank you all for joining us today. And before we begin, I would like to take just a moment to introduce you to our presenter, Dr. Tyler Brown. Dr. Brown joined Shepherd Center in August 2020 as a rehabilitation psychologist. Prior to that, he earned his BS in psychology at Lander University in Greenwood, South Carolina, an MS in psychology at Augusta State University, and his MS in clinical medical psychology and PsyD in clinical psychology at Mercer University in Atlanta, Georgia. Dr. Brown completed his clinical internship at Wichita State Counseling Center and Kansas University School of Medicine, Wichita, and as part of the Wichita Collaborative Psychology Internship Program. He completed his postdoctoral fellowship at MedStar National Rehabilitation Hospital in Washington, D.C. Dr. Brown has a passion for providing evidence-based treatment to individuals and their families, dealing with a variety of complex medical conditions, including spinal cord injury, acquired brain injury, multiple sclerosis, chronic pain, and amputation. Dr. Brown is also an adjunct professor at Mercer University. We will have time at the end of today's webinar for some questions. So if you'd like to, you can submit those in advance through the Q&A box at the bottom of your screen. And with that, I will turn over today's presentation to Dr. Tyler Brown.
Thank you. I just want to say it's a pleasure to be here today. I really enjoy doing these kind of talks, so I'm really glad that I could be a part of this today, and I really hope that you learned something, and I look forward to hearing what some of your questions are at the end. So without any further delay, we'll go ahead and get started. So what I wanted to start with in terms of this conversation, and we're not going to spend too much time on this, but depression as a representation from the general population. So according to the NIH, within a given year, almost about 20 million adults will have a major depressive episode. We'll talk a little bit about what that means here in a little bit. But within that year, and that represents about roughly 8% of adults. It tends to be a little bit higher in women than in men in the general population. There's some evidence that suggests there's a little bit of probably a help-seeking bias there, where women are more likely to seek help than men, so that number might be closer together. It tends to be highest in young adults, so about 18 to 25. So we see about a 15.2 prevalence rate there. About 5.3 of individuals with major depression will have a severe impairment that might require them to be hospitalized or call out sick from work, just to cause some major disruption to their daily living. It's actually the leading cause of disability in adults that are age 15 to 44 in the United States now. And since I know a lot of us work with adolescents, it's even a bigger problem in adolescents in terms of prevalence rate. So within 1 year, about 15.7% of adolescents will have a major depressive episode, and about 11% of those people will have a severe level of impairment that'll keep them out of school or participating in their normal activities. So as we talk a discussion about depression, I don't think that we can have that discussion without also mentioning suicide, which can often be caused because of depression. So again, just talking about the general statistics, there are roughly in a given year about 45 to 50,000 completed suicides. It's the 10th leading cause of death overall in the United States. However, in certain age populations, that's different. So for example, in people aged 10 to 34, it's the second leading cause of death. And in people aged 35 to 44, it's actually the fourth leading cause of death. Within a given year, about 12 million adults had serious thoughts of suicide. That's about 4.8% of the population, and it's about 11.8%, again, in that vulnerable risk range of 18 to 25. So about 3 of the people that they analyzed, about 3.5 million had made plans. So they had some sort of plan to actually attempt suicide. 1.4 million attempted their plan. And then of those, 1.2 million made plans and had an attempt versus 217,000 had an attempt without a plan. That's important for reasons we'll talk about in a little bit. Basically, there is what that's telling us, and it's kind of a good thing, is most of the time people aren't just spontaneously deciding that they're going to end their own lives. There are factors that lead up to that, and planning and behaviors that we can look out for and catch somebody before they might attempt suicide. And as you can see from this graph here, we'll talk a little bit about this in a minute too, but you can see the overall rates have slightly increased. And another thing you'll notice from this graph is that men tend to have more completed suicides than women. And one reason for this that we'll mention is women are more likely to attempt suicide, but men are more likely to complete suicide. And that's often because of the means that men choose, with like firearms and more violent means, also leading to higher rates of completed suicide. So now kind of shifting gears here a little bit into the specific topic today. So as we look at depression prevalence rates in spinal cord injury, they're kind of all over the place, and there can be a wide range depending on how you measure depression, how you selected your sample size and your population. So Bombardier is a researcher who does a lot of depression and SEI research, and he conducted a literature review where he just looked at a whole bunch of different articles, and he found that the occurrence rate of major depressive episode could range anywhere from 9.8 to 38% depending on how depression was measured. When we look at an average, what we're more likely to see is roughly 1 in 4 to 1 in 5 individuals with SEI having a major depressive episode within a given year. Bombardier did a different study where he used the PHQ-9. That's the patient health questionnaire, and that's kind of the gold standard measurement of depression right now in the healthcare setting. He found a prevalence rate of about 24.6% of the patients in that study screened positive for probably having major depression in a sample of 244 individuals that had spinal cord injury that were based in the community. So when the researchers looked at the demographic variables of that, we see pretty similar to what we would expect in terms of the overall population of spinal cord injury. 77% were men, 61% were white. There was a 43.1 mean age, and 43% of the individuals had a tetraplegic level injury. What he found in terms of risk factors, so what demographic variables were more likely to predict depression, he found that the age group 20 to 29, people who had not completed high school, people who were not working or actively attending school, and people who were less than 4 years removed from their injury were the most vulnerable or the most likely to have a major depressive episode. The researchers reported that those individuals were more likely to not be participating in rewarding or meaningful activities and had overall lower self-efficacy. And when we say self-efficacy, what we mean is our feeling or attitude that we can influence our environment, right? So that we have some sort of control over our situation and we can make changes to influence our lives. I included another research here. This is a meta-analysis. Basically, all a meta-analysis is you take a whole bunch of different studies and then you analyze them statistically to try to find trends. Whereas maybe one study just looks at 100 or 200 people, when we conduct a meta-analysis, we can be looking at thousands or tens of thousands of people. So this meta-analysis found a 22.2% prevalence rate of depression across about 35,000 total participants. So still within that ballpark or that figure that we quoted with like 1 to 4, 1 to 5 individuals. One thing to note there, though, that study didn't just look at major depression, it looked at all depression. And we'll talk again about the differences of those here in a minute. In terms of suicidal ideation and behavior in spinal cord injury, I think a few things that we need to talk about up front is one, that as many as 6.8% of individuals that acquire a spinal cord injury acquired their spinal cord injury as a result of a suicide attempt. This is usually from falls. So falling from heights, bridges, buildings, things of that nature. When we talk about post-SCI and all causes of mortality, about 5.8 to 11% of SCI deaths are from completed suicide. So it is a major issue. The means of suicide attempt are most often gunshot and overdose of medication. And we'll talk a little bit about why that can be important at the end when we start talking about what can we do to help people who might be having some suicidal thoughts. So ideation is more common in SCI, just like depression. It's more common in SCI than the general population. So one study actually took a group of SCI participants as well as non-SCI participants and matched them together to compare suicidal ideation in those two groups. So in SCI, they saw about 35% ideation of any type versus 10% in the general population group. 17% of the people with SCI had a previous attempt of suicide versus 9% in the match group. And at a 3-month follow-up with the individuals, 47 of the SCI group, which is about 11%, had some sort of plan to commit suicide. At a 6-month follow-up of just 32 of those individuals, 13 still had some sort of plan. So kind of shifting gears here a little bit and talking about some of the risk factors. One thing, and it's also important to talk about this in the context of suicide and depression, is a lot of the risk factors actually overlap. So having a pre-existing mental illness is a huge risk factor. So if you are working with somebody who had major depression before they acquired a spinal cord injury, then their risk of having depression after a spinal cord injury or some sort of major life change is increased. But just because they have some sort of pre-existing mental illness doesn't mean that they can't develop that after the injury, right? So post-SCI mental health diagnoses are also important. Age, so we've already talked a little bit about that, particularly that 20 to 29 year range. Employment status is really big. Really what a lot of these boil down to are quality of life type situations, right? So people who are employed tend to have a steady income. They tend to be going to work, doing something fulfilling, engaging in their lives, and they're not so idle or don't have a lot of that free time to sort of just spend with themselves. Poor social support is a predictor and a risk factor for both suicide and depression. So not having, whether it's family, friends, whatever your social support is comprised of, not having adequate social support is a strong risk factor. Being removed less than 4 years from SCI. We already mentioned low self-efficacy and reward. One thing that I like to point out here that outside of the realm of just mental illness that can be a huge predictor of, well, suicidal ideation and depression is chronic pain. So people that have long-term chronic pain that's refractory, and what I mean by that, it's very resistant to treatment, where they've tried a bunch of different treatments and they just can't seem to get their pain levels under control, is a risk factor for both major depression and suicidal ideation. For suicide, in terms of completing suicide, access to means is an important risk factor. So if they have guns in the house, or if they have a lot of different medications that you could easily overdose on and kill yourself. In general with suicide, and I mentioned this a little bit earlier, but females tend to are more likely to make attempts at suicide, but men are more likely to complete suicide. And the last thing I have down there highlighted that I think is really important is the general feeling that people might have when they're severely depressed. So generally when people are really depressed, they're feeling hopeless, helpless, and powerlessness. So they feel like there's nothing they can do about their situation. Their situation isn't going to get any better, and they don't have any coping skills or abilities to be able to manage themselves through that situation. So I wanted to spend a couple of minutes talking about, as a clinician, how I diagnose depression, not so much expecting you as peer supporters to be able to diagnose depression, but just so you can understand what sort of risk factors or variables or behaviors we're looking at here. So when we diagnose mental health as clinicians, we diagnose these based on a syndromal model. Basically, what that means is there's not a blood test for mental illness. We can't give someone a thermometer or a blood test or some sort of objective test like that to say, okay, well, you tested positive for depression. Instead, with syndromal models, what we're looking at is clusters of symptoms that group together to say, okay, if a person meets these criteria, then I'm going to diagnose this person with major depression or something else, right? So that's important, I think, for you, because a lot of those behaviors are going to be the same things that you're looking out for in the people that you're working with. It's important to differentiate sadness from depression, right? I think we all get sad at some point. Sadness is a normal human emotion. Really, a big difference between sadness and depression, one is how chronic it is. So generally when we're sad, we might be sad for a little while about something very specific, and then we tend to kind of snap ourselves out of it after maybe a day or two or a week, where depression tends to be more chronic. Another thing is that when we're sad, we can often be kind of cheered up, right? Like we can be provided with distractors, or maybe a friend takes us out and gets our mind off of things, and we can be cheered up. A lot of times for people with depression, that's not the case, right? So they have that feeling of hopelessness and helplessness about their environment. So even if they engage in something they might normally enjoy, they might not cheer up, or they might not actually feel any better. In terms of the different diagnoses as a clinician I make, there are different patterns of behavior that we diagnose differently. Major depressive disorder is categorized as a disorder that's usually a little bit more severe in terms of the symptoms, but tends not to be as persistent. So they tend to go through episodes where maybe they're depressed for a couple of weeks in a row, or a month or two in a row, and then they'll get a little bit better, and then maybe they'll get depressed again. So there's a little bit of a cycle to it. Persistent depressive disorder tends to be a little bit more mild in terms of the symptoms, but more chronic. So they're persistently depressed for a long period of time, months and months at a time, or years at a time. Oftentimes especially in the acute setting, so if someone has just had a spinal cord injury and they're coming to us and they're trying to grapple with all the changes in their life, they might have symptoms of depression and anxiety, but they might not meet criteria for something like a major depressive disorder or persistent depressive disorder. So a lot of times in this setting, we're diagnosing what we call adjustment disorders, which is just depressive symptoms or anxiety symptoms that are present in some sort of major life change, but still requiring some level of psychological intervention. And then we'll talk a little bit about what atypical depression means in a minute, but this is just depression that manifests differently than what we would normally think. I think when we look at someone who's depressed, we often think of them being kind of flat affect and just kind of down and maybe looking a little bit slower than usual. But there are other types of depression as well. A very common example of that is in men, especially young men. Depression can often look like really intense irritability or increased sensitivity to criticism, things like that. So it might not necessarily look like what we typically think of when we say someone looks depressed. So I said that we would talk a little bit about major depressive episodes. So on the left column, that's actually the criteria for a major depressive episode. And these are oftentimes some of the warning signs you can look out for in someone who may or may not be depressed. So if you're a clinician like myself and you're diagnosing major depressive episode, one of the first two criteria are both have to be present. So they have to have some sort of depressed mood or intense sadness for most of the day, every day for 2 weeks. They also have to have a diminished pleasure in activities. That means if there's something that they would normally enjoy doing, even if they were to do that thing, it wouldn't really bring them any pleasure. Other things that you'll often see that you can look out for are significant weight loss or weight gain in a short amount of time, or major appetite changes, slowing down of thought or physical movement. So oftentimes people are depressed, think more slowly, and they tend to move a little bit more slowly too. Significant changes in sleep in either direction, either sleeping too much or sleeping too little, having intense fatigue or loss of energy, having poor concentration, so not being able to focus, not being able to pay attention, feelings of worthlessness or excessive guilt. So they'll have really bad feelings about themselves. I'm worthless. I'm not capable of doing anything. I'm a burden to everybody, those types of things. And as well as thoughts of death and dying and suicidal ideation. On the right-hand column, I have some other signs of depression that aren't necessarily criteria for a depressive disorder, but they're still important things to look out for. So I already mentioned like an increased reaction to criticism or rejection, having angry outbursts or irritability or frustration that's unusual for that person, having a lot of anxiety or restlessness about the situation, ruminating on thoughts. So just ruminating and thinking about, oh my God, my life was so much better before. It's never going to get back there. Like things will never be good for me again. And just sitting there and just thinking about those negative thoughts over and over and over and not being able to snap out of that pattern. Changes in performance or school or work. So grades dropping, work performance becoming poor, things like that. People who are depressed will often socially isolate, so they'll stop reaching out, they'll stop talking to family, they'll stop interacting with friends. Substance misuse, this can be alcohol, it can be illicit substances, or it can even be the medications they're prescribed, with opioids being a really big culprit there for people self-medicating with pain medication to also relieve emotional symptoms. Non-suicidal self-injury, especially in younger people and adolescents, so things like cutting, burning, pinching, behaviors like that. In older adults, there's something that we call pseudo-dementia, which is where an older person will start having memory complaints, but they're not actually having a dementia. It'll often be related to depression. And once that depression clears up, their memory often just goes back to normal. Already mentioned feelings of hopelessness, helplessness, or powerlessness. So if they're talking about how their situation's never going to get better, there's nothing they can do to make their situation better, that's language to look out for. Having that kind of that flat or restricted affect, having unexplained increase in physical complaints. So that's another maybe atypical symptom. So if someone's all of a sudden complaining more about how they're not feeling well and they're more achy than usual, a lot of times mental illness can manifest in physical ways. And highlighted in red there, I have decline in self-care, because decline in self-care can be a very common symptom of depression, but I think it's especially important to point out in SEI, because if someone in the general population has a decline in self-care, maybe they stop bathing, maybe they stop brushing their teeth and just generally taking care of themselves. That's not necessarily an immediate threat to them, but for someone with a spinal cord injury, not paying attention to things like their weight shifts or bowel and bladder care and things like that can cause immediate consequences that are severe, right? So something really to pay attention to is that overall decline in self-care. In terms of warning signs of suicide, so we've talked about warning signs of suicide. Let's talk about, or of depression, let's talk about some for suicide as well. So obvious one, talking about wanting to die or kill themselves, looking for ways to kill themselves. So like searching for online for ways to buy a gun or how to buy a gun. If they're not a gun owner, all of a sudden they have an interest in that. Looking at what kind of medications could cause someone to overdose, things like that. Talking about feeling hopeless or not having any real reason to live. Feeling like their future's not bright or there's nothing coming up to look forward to. Talking about feeling trapped or feeling like they're in unbearable pain. Talking to others about how they're a burden to everyone around themselves. Increased use of alcohol and drugs, not just because that can be life-threatening in itself, but a lot of times when people consume alcohol or drugs, they have a lower level of inhibition, right? So they're more likely to engage in impulsive behaviors. So if someone is suicidal and then they drink really heavy, then the chances that they complete that suicide or attempt that suicide go up a lot. Acting very anxious or agitated or behaving very recklessly. So if someone has lost the will to live, oftentimes, even if they're not actively trying to attempt suicide, they might start just engaging in really risky behavior just because, well, they don't really care if they live or die anymore. So if they start behaving really reckless, that's another warning sign. So a lot of the depressive symptoms like sleeping too much or too little, that social isolation is another really big warning sign. Showing a lot of rage or a lot of outbursts or talking about seeking revenge on people. Extreme mood swings. So kind of going from really happy and okay to not feeling very good. And another one that you really have to look out for, if someone's like depressed for, let's say, a long period of time. Let's say someone has been depressed for like 2 months straight, and all of a sudden, just like out of the blue, they're doing better. That can actually be a warning sign for suicide, because what that could indicate is that they're finally planning on going through with that, because they've been building up all this pain and this hurt, and then all of a sudden they're like, okay, I'm about to have my way out. So that might actually make me feel a little bit better, knowing I don't have to keep suffering for much longer. Things like giving away all their possessions or talking about giving away all their possessions. And then black box warning for some antidepressants. I have this there because for adolescents, and it kind of goes back to what I just said about changes in behavior. If an adolescent is very depressed and they're started on certain types of antidepressants, before they reach a point where their mood is improved, where they feel better and they want to carry on with life. So think of it like this. So if someone is so depressed and they're suicidal, they might not have the energy to carry out whatever plan they have. But all of a sudden, if they're put on a medication that improves their mood, then they might reach this narrow window where I'm not feeling good enough to live, but now I have enough energy to carry out my plan for suicide. So because of that, particularly in adolescence, there's actually a black box warning that physicians have to review with patients if they're prescribing antidepressants to adolescents. So talking about suicidal ideation as an increasing or escalating concern, not that I expect anyone in here to be able to do a risk assessment, but as a clinician, we often think about it in terms of what their overall risk level is. And that generally starts with thoughts of death or dying. Like at some point, almost everyone in their life is going to have some thoughts of death or dying, or just saying, oh man, I'd be better off if I was dead. It doesn't make them suicidal, but it's what we call passive thinking. Then you bump that up to ideation without plan or intent. Yeah, I wish I was dead, and maybe I think about killing myself, but I don't have a plan to do so, and I don't have any intention to do so. Then kind of comes planning. You start thinking about, okay, well, if I were going to do it, how would I do it? And then with a plan comes available to mean. So if my plan is to try to attempt suicide with gunshot wound, then if I have access to a firearm, all of a sudden my risk is very high and my intent level. So now I'm actually going to carry out that plan. So I think kind of the bread and butter of this conversation and what a lot of you are asking for, now that we know warning signs, risk factors, and the prevalence rates in the SCI population, let's talk a little bit about how you as peer supporters can help facilitate or start that question. And I think the hardest part, honestly, even as a clinician sometimes, is just starting the conversation. So I encourage people to use statements that have some component of just making an observation, right? You don't necessarily want to accuse somebody of being depressed. Like, hey, you look really depressed. But instead of just making an observation about changes in their behavior and taking ownership of saying, this is something that you're observing. So for example, I've been feeling concerned about you lately. Can we talk a little bit about that? Recently, I've noticed some differences in you and wondered how you're doing. I just wanted to check in on you. I wanted to check in with you because you've seemed pretty down lately. The big thing here, I think that's important to respect people's autonomy is to be able to ask for permission. So, recently I noticed some differences in you and wondering how you've been doing. Would you mind if we talked a little bit about some of what I noticed, or can we talk a little bit about how you've been feeling lately? So I'm pointing out a behavior and observation that I have, and then I'm asking their permission to be able to talk about that. And when we do that, we're kind of respecting their autonomy. We're not really putting them in a corner or putting them in an awkward position where they feel trapped. We're giving them an open floor to talk about their feelings and talk about how they're actually doing. So once that conversation gets going, I think the next hardest part can be, how do I keep that conversation going? How do I find out more and engage them? So conversation starters that elicit more discussion are often open-ended. So it's not like, are you depressed, right? That's a yes or no question. But when we ask open-ended questions, we open the door for them to have a discussion with us. So when did you begin feeling like this? Did something happen that made you start feeling this way? How can I best support you right now? Have you thought about getting help? And a lot of these involve general active listening versus solving their problem. When we know that someone we care about is hurting, we often want to just help them immediately, right? We are compelled to want to give them an immediate answer or solution. But the problem with depression, things don't really work that way. Sometimes you might wind up giving them a suggestion they've already tried, or you might give something that's just not very helpful to them, and maybe that leaves them feeling a little bit alienated or invalidated because they think you don't understand. But when you give them an open forum to be able to talk about their experience, you're getting to understand exactly what it is they're going through. Maybe they'll talk about what they've tried, what their current struggle is, and that can open up a deeper, richer conversation. And that involves the use of active listening, right? Just being there for that person, listening to their experience might do so much more good than just sitting there and being like, well, have you tried exercising? Have you tried calling your doctor? And just jumping straight to problem solving. So some of the do's and don'ts about talking about people with their depression. You're not alone. I'm here for you for this tough time. So validating their experience, letting them know that you're there for them. It might be hard to believe right now, but the way that you feel will change over time. Please tell me what I can do to help you right now. Even if I'm not able to understand exactly how you feel, I care about you and I want to help you. You're important to me. Your life is important to me. When you want to give up, tell yourself you will hold on for just one more day, hour, or minute, whatever you can to manage. So be comfortable discussing those concerns with the individual, right? Again, you don't have to solve their problem in that moment. You just have to be willing to have an open conversation with them. I often encourage people to explore their own discomfort and anxiety. Okay, I feel compelled right now to give them a solution. Why do I feel that way? Why do I want to fix this problem so bad? Why does talking about someone else's depression make me feel so vulnerable and make me feel so uncomfortable and make me feel so anxious? Because a lot of times that's something I think that we need to work on a little bit in order to be able to have these kind of conversations. And I would also encourage you to set realistic personal expectations. Your role for someone who's maybe feeling depressed or possibly suicidal isn't to fix them. It isn't to make them feel better immediately in that moment. It's to sit there and be with them and let them know you care about them and that you want to hear their experience and you want to help them find help, right? So a lot of times I think that anxiety piece comes from our own unrealistic expectations of ourselves that we have to fix this person's problem now, when that's really not the case. Things to avoid, I know some of these might seem a little bit obvious and I'm sure you don't do them, but just to go over them real quick, things that are invalidating, like telling them that it's all in their head. Everyone goes through tough times. So avoid platitudes, right? Avoid those common expressions of speech that we all say, like, oh, you'll land on your feet, or you'll figure this out. Things like that aren't usually very helpful for people. Why do you want to die when you have so much to live for? It doesn't matter how much subjectively you feel they have to live for. If that person's feeling hopeless and helpless, then as far as they're concerned, they don't have anything to live for. And pointing out that they have things to live for isn't going to make them feel any better. I can't do anything about your situation. So you don't want to make them feel more hopeless or helpless than they already are. Just snap out of it, right? That's not very helpful. And you should be feeling better by now. And in general, I would encourage people to avoid advice giving and saying, you should do this, you should do that, or you should. Using the word should is an absolute, right? You're like telling them what to do or telling them what's going to work for them. And I don't know about you, but when people tell me what they think I should do with my life, I usually don't respond very well to that. So briefly, I just want to review some protective factors, especially when someone is severely depressed or suicidal, things to look out for that are likely that you can harness or utilize or to predict someone's chances of wanting to continue to live. So coping and problem solving skills, right? How well can this person cope with the situation? Okay, well, they really like to go out and hang out with friends. They have really good social support. They're likely to call their social support. They're likely to call their peer mentor or call their clinician or call their doctor. They have good help-seeking behavior. Those are good coping skills. Cultural and religious beliefs that encourage suicide are often very important. I've worked with a lot of people that have suicidal ideation, and a lot of times the only thing keeping them here might be the fear that they're going to be persecuted or they're going to be sent to hell or whatever it might be if they complete suicide. So that alone might be the only thing that's keeping them here on earth at that moment. Their connections to their friends, family, and community support, right? So not only utilizing that support, but having immediate access to people around them that can rally around them and provide them with support when they're at their lowest points. And having not only supportive social relationships, but having supportive care providers as well. So feeling supported by their counselor, their peer mentor, their physicians, whoever that might be, that they're healthcare professionals. What's their availability of physical and mental health care is another really important consideration. So what's their access to care like? Are they in a big city like I am, like Atlanta, Georgia, where there's psychologists and counselors all over the place? Or are they in the middle of Montana, where access to care is very low? And then limited access to lethal means among people at risk. And we'll talk a little bit about that here in a minute. So a lot of times the level of care is linked to the severity of risk. So for example, if someone's having passive thoughts of death or dying with or without plan or intent, some things that you can do to support them. And I know Rebecca wanted me to mention that if you need it, she would be willing to send out the policy on how to deal with peer mentees that disclose to you that they're having suicidal ideation. But just some very basic strategies or things that we encourage people to do if they're having depression or suicidal thoughts. So oftentimes when people are dealing with mental health issues in general, their primary care physician is the first person they'll go to. It's not to a counselor or a mental health professional or some sort of specialist. They'll go to their primary care physician, and primary care physicians find themselves treating a lot of mental illness and are actually still, I think, the #1 prescriber of antidepressants. Encourage them to seek mental health services. I have some resources at the end to help with that. But insurance will often, if you call your insurance company, they'll often provide referrals that are in network. Psychology Today is something I'll talk a little bit about at the end. A lot of times your primary care physician, if you go through them first, they'll be connected to mental health providers that they'll then refer their patients to if they feel like that's warranted. And then even participation in local support groups can be really important. As risk level increases, obviously the situation becomes more dire, and a lot of times the intervention has to be a little bit more immediate and invasive. So for example, removing someone's access to the means. So things like if they have firearms in the house, or if they have a lot of medications like opioid pain medications or antidepressants and access to alcohol, then that needs to be removed from their vicinity. Things like household poisons, sharp objects, things like that that they could use to attempt a suicide need to be removed from them, or they need to be removed from those situations. Involving their care partners or their family members to help make sure that they have adequate supervision till help can be found, so not leaving them alone. Encourage them to avoid intoxicating behaviors. So that kind of goes back to what I said earlier. If someone is on the border of thinking about suicide, well, if they drink alcohol and they become inebriated, or they take any kind of substances, then that chances of that attempt become more likely. And again, I have some of these resources at the end, but calling 911, calling the National Suicide Prevention Hotline number, going to the emergency room, or calling an established provider are appropriate as well. And again, Rebecca wanted me to remind you of the Peer and Family Support Program's crisis protocol. So I wanted to talk really quick about barriers to help-seeking behavior. 40 to 50% of individuals from the research say that low perceived need or lack of motivation is actually their number one barrier. So it's not necessarily an access or financial barriers as much, but about half of people just say, well, I don't really want to go. I don't really think I need that right now. You know, maybe I'll snap out of it. I'm going to wait. It's those types of things. But financial barriers do also play a role. For those individuals, you can either help them find public mental health resources, so like free clinics, or a lot of times psychologists and mental health counselors will offer pro bono services, or they'll offer services based on a sliding scale based on someone's income. Ease of access. So again, my example of someone living in the middle of Montana. The good news is that telehealth is becoming more and more common. Here at Shepherd Center, we've started using a lot of telehealth, especially through COVID. So people are getting greater access to care, both medical care and mental health care, as a result of telehealth. Stigma is another really big one. And the way we can tackle stigma is normalizing help. Like, it's okay to be depressed. It's okay to seek help. We all need help sometimes. So normalizing mental health issues. Family members can often help by offering to attend a first session or going along with somebody to provide them support, because meeting a stranger and talking to them about a lot of your intimate details and problems can be very stressful. So a lot of times I see people who've never seen mental health before, and they come in and they're a little bit shy or anxious at first because they don't know what the experience is going to be like sharing all that information. And just misunderstanding of mental health models and treatments in general. So like TV often looks like mental health is just you sitting on a couch talking about your problems, but modern mental health is often a lot more interactive and equal involvement, and it's about building coping skills and working together and building plans. It's not just sitting on a couch just talking about your problems. So I know one question that had came up specifically for this conversation that I wanted to review is, what if you do feel like someone is depressed and they have sort of a low motivation to want to seek help? What do we do with those individuals? And motivational interviewing is a tactic that was developed a long time ago, and it's a style that was developed to help facilitate behavioral change through open conversation. So it started as a treatment for like substance abuse, but what we found is it works very well in all kinds of different environments. And what motivational interviewing really is a respectful collaboration. So we're working together and we're generating a conversation together to be able to help you solve your problem. It's not me as a professional talking to you, telling you what you need to do. And it's meant to help elicit what we call change talk and allow the person to explore their own ambivalence. Well, I really don't feel like talking about my mental health issues. I really don't feel like going to see a professional. Okay, well, what might be some benefits to seeing a professional? Well, I don't know, maybe it would be good to talk to somebody. At least I could vent. So that's what we're looking for, that change talk, that ambivalence. What are the things that are going to help them understand that seeking mental health treatment could be good for them? DRESS is an acronym that we use in motivational interviewing that just means explore discrepancies. Okay, well, you're really depressed and you're saying that there's not anything you can identify you've been able to do about it, but at the same time, you feel like seeking help's not a good option for you. Tell me more about that. Rolling with resistance. Okay, so you don't want to go see a psychologist right now. What might be some other things that you would consider? Would you go see your primary care physician? Would you be willing to talk to me more? What are some things that maybe you would consider? Expressing empathy. And then support self-efficacy. So recognizing like, hey, like there are some things that you can do to change your situation. Let's talk about some of those things. Like help them recognize that there are things that are within their control. The way that you can go about this, and this is again a part of motivational interviewing through empathic listening, is what we call OARS. So this is a very important acronym to remember. So asking open-ended questions, making affirmations, involving reflective listening, and summarize listening. So open-ended questions basically allow for more information. We've already talked a little bit about that. So that's things like, what would you like to change about your life? What changes have you already tried to make? What have been the barriers for you to seek help? So that allows them to give you more information about what's been going on with them and where their thought processes are. The A for affirmations helps them overcome any self-sabotaging or negative thinking. So compliments or appreciating and understanding where they're at. Okay, well, you've been struggling for this for a while, and right now you feel like there's not a whole lot that you can do about it. And it's very difficult for you to see any way out right now. You're feeling really down and helpless and hopeless about the situation, and that's got you feeling really bad about life. And noting the person's strengths and efforts. So saying things like, despite all this, you still came and were willing to talk to me about this, and you're engaging in this conversation right now, or maybe you're still going to work, you're still going to school. So there's still things that you're doing that are helping yourself right now. Reflective listening, so that expresses their ambivalence. So rephrasing their statements to capture the implicit meaning of the feeling. So what you're telling me is you haven't considered seeking help because you feel like it wouldn't do you a whole lot of good. At the same time, you recognize that you need to do something about your situation. And it helps them encourage sort of a self-exploration and helps them understand what their motivations are. So basically pointing out things like, oh, okay, yeah, you're right. Like, I do want to do something about this. And maybe there are some things that I haven't tried. And maybe I'm more willing to try those things now as I start to think about or process what my barriers are. And then last, providing a summary of listening collects all the information that has been said. You can reflect back to the earlier part of the discussion, and you can sort of draw together a central message for the conversation. So summarizing is just saying, today we talked a little bit about your depression. You noted a lot of the things you've been struggling with and the things that have changed in your life that you want to improve. We talked about some of the options that you could possibly explore, and here are the ones that you said that you would consider. And that helps them sort of wrap up everything with a bow and then be able to help them set up their next steps for what they're going to do. In terms of listening for change talk, what are the types of things that you need to actively be listening for in terms of what they're saying? One is a desire. So what is their desire to change? So what are they expressing by why change would be good for them? Two is ability. So how do they feel like their ability is at making a change? Reasons. So what are their best reasons to be able to change? Because those are your main sources of motivation. Saying, okay, well, I want to get back to work, or I want to get back to school, or I want to feel better, or I want to be able to go back out with friends again. Those are things to listen for because those are going to be the things that are going to motivate them. What's the level of need? So how important is it to them to address this issue right now? And then commitment. So how likely are they to follow through with whatever plan you arrive at? So I know we're kind of short on time here. At the very end, I listed a bunch of resources that can be important for you to explore. Ones I want to highlight very quickly are like the National Suicide Prevention Hotline. It's a 24/7 hotline, and it's a really good resource if someone is struggling because they can always find someone to connect to. Similarly, the national hotline, I think, is also 24/7. It's not necessarily suicide specific, but if someone's struggling, they can call that and have someone to talk to that's available. Findtreatment.gov is a search engine to be able to provide resources in a person's area or community. And in general, SAMHSA and the National Alliance on Mental Health are two major organizations that, if you explore their website, offer a lot of very good information on depression and resources, and as well as substance abuse. So SAMHSA has a little bit more of a substance abuse specific lean. As I mentioned earlier, primary care physicians are often a first line stop for mental health related issues. So people will often go to their primary care physicians for that kind of for referrals or medication. Psychology Today is a private publication, but their website actually has a classified section where therapists can post their own bios, and there's some really good filters under that search engine. So it's a really good resource for people to be able to find therapists in their area, and it has a lot of different filters. So you can filter out things like teletherapy, support groups, treatment centers, therapists, and even psychiatrists. And then the Model Systems Knowledge Translation Center for SEI has a lot of very good resources for SEI and depression, SEI and mental health, and a lot of other education in other areas of a person's life after SEI that are really important. All right. Thank you very much. Sorry I went a little bit over on time there.
Thank you so much, Dr. Brown. And I just mentioned in the chat box that if anyone has any questions, they can enter them into the question and answer box, and Dr. Brown would be happy to answer them.
One thing I'll say real quick is we're waiting for any questions to pop up. You know, I mentioned motivational interviewing, and I gave a couple of tactics for it. And I would encourage you, if you ever get an opportunity to, because you could spend hours talking about motivational interviewing. When I was in grad school, we actually did like a 6-hour-long course. So you can spend a long time talking about it. If you ever have the opportunity to take a course or a class in motivational interviewing, I think it can help tremendously. And it's just something that was a little bit outside of the scope of this lecture to be able to talk about broadly.
Okay, so someone would like to know, how does MDE relate with bipolar disorder?
So bipolar disorder is characterized by having different episodes of depression and then what we call mania. So mania is sort of the opposite of depression, right? It's like an elation or feeling a sense of grandiosity. When it gets really bad, so what we call bipolar 1 disorder, it can even reach a level where it's psychotic. So they might actually have hallucinations or delusions, a lot of impulsive behaviors like reckless spending, gambling, increased sexual behaviors, increased drug use. So it's sort of the opposite of depression. So someone has bipolar disorder, they typically cycle between those manic episodes and depressive episodes.
Okay, and then there's a follow-up question. I'm asking if those two can be easily confused.
Sometimes, yes. So I think a lot of it would relate to, so a good example of that is sometimes when people are manic, they can present as very angry or irritable. And I also mentioned that that could be a presentation for depression. I would say ways to sort of weed some of that out might be how that person is feeling about themselves or their situation or their life or their future. So someone with mania is much more likely to report, oh, great things are coming my way and I'm going to be the next big thing. So there tends to be that elevated sense of self, where with depression, there tends to be a lower sense of self.
Okay, and then so question is prefaced by a comment. Thank you so much for this presentation. These are really heavy issues, and as mentors, we try to delicately navigate them. And her question is, I'm a really open and honest person, especially as a peer mentor. I find when I share my own experiences, it helps her peers to figure out a particular situation. She wants to know, is it okay to share her struggles with depression and suicidal episodes with her peers, or does that somehow encourage them?
I don't think it necessarily encourages it. That's one thing I meant to say about one thing that really makes people uncomfortable about approaching suicide is this sort of irrational thought that if we bring it up, we're going to plant that idea in their head. If someone is thinking about suicide, they're thinking about suicide. You aren't going to plant that idea in their head. It's interesting in psychology, there was once a school of thought a long time ago, like in Freud's era, that we should never self-disclose. And we've really moved away from that. Really, in grad school, what I was taught is what's the point of your self-disclosure? Meaning it would be inappropriate for me to self-disclose as a way for me to vent about my own problems. So if I was just like, yeah, I have that problem too, let me talk to you about how like that's interfered with my life. So then the conversation comes about me. I think that's different than what you're talking about, where you're saying you want to use that as a way to normalize and validate their experience and let them know that you understand and empathize with their experience. And I think that's totally appropriate. It's kind of a judgment call, I think, sometimes when we have to think about where does that line cross with oversharing.
Great, thank you very much.
Mm-hmm.
I think we have time for one more question, if anyone has a last question. And Dr. Brown, just while we're waiting to see if anyone has a last question, I just wanted to ask, when people do decide that they'd like to seek out a mental health professional, do you have any sort of tips about, maybe some questions that people should ask of that person and how people should feel empowered to, find someone who they really feel is going to be a good fit for them?
Yeah, I often tell people it's not like maybe a medical provider where you don't necessarily have to like the person or they don't necessarily have to be the warmest person to get along with them. What I encourage people to do, and Psychology Today is a great resource for this because it allows you to pre-filter, because counselors on there kind of write their own bio and philosophy. So I think if you use something like Psychology Today, you're more likely to find somebody who's a good fit or a good match for you just by being able to read their bios. But I encourage people, when it comes to mental health treatment and seeking a provider, it might take 1 or 2 times, and that's okay. Like, it's okay to go to one session and then not really gel with that person and maybe want to try again. And that's a little bit different than maybe what we're used to when we're finding a medical provider. That's important too, right? Like, I know with my primary care physician, I want to feel like they actually care about me. But I think that's especially important when you might be spending some time with somebody where you're talking about a lot of your most intimate thoughts and what's going on in your life. So I would encourage people to use resources like that. You can call a practice sometimes, and sometimes people will even be willing to talk to you about, okay, here's my philosophy, here's how I view therapy, here's the populations I work with, here's the types of things that I treat.
Great.
And you're finding that more and more people are kind of going into specialties.
Okay, and then we have one last question. Someone would like to know if they can have a copy of your PowerPoint. I just wanted to let everybody know that we will be sending everyone who attended today a link to a recording of today's webinar, so you can view those slides there. And so with that, we will wrap up today's presentation. I just want to say thank you so much to Dr. Tyler Brown for presenting on such an important topic. It was a terrific presentation with lots and lots of great information for our peer mentors. So thank you so much. And again, as I just mentioned, there will be a recording of this webinar up on our Reeve Foundation YouTube channel. We'll be getting a link to that recording out to everyone who attended within the next few days. And I just want to thank everyone again for joining us today. And I hope that you enjoy the rest of your afternoon. And thanks again to Dr. Tyler Brown.
Thank you so much for having me.